Welcome to CoI'Q, a first-of-its-kind video program about health innovators, early adopters, and influencers, and their stories about riding the roller coaster of healthcare innovation. I'm your host, Dr. Roxie, founder of Legacy DNA Marketing Group, and it's time to raise our CoI'Q. Welcome back to the show, CoI'Q listeners. On today's episode, I have with me Dr. Grace Terrell. She is a primary care practitioner. She's also the president and CEO of Envision Genomics. Welcome to the show.
Thank you very much. I'm happy to be here.
So for our listeners who don't know who you are just yet, just take a few minutes to let us know a little bit about your background and what you do.
Sure. So as you mentioned, I'm a primary care physician. I'm a general internist by training and still see patients in that venue. And back in the late to mid 1990s, I founded with a group of other people an organization called Cornerstone Healthcare that was a multi-specialty group that grew to about 375 docs in Central North Carolina that became one of the very first organizations down what's now called the Move to Value movement. So we were able to lower the cost of care, improve the quality, do some of the very first medical home things. After that, I founded a population health management company called CHESS, which is now helping other organizations actually do some pretty innovative things within the care model redesign space. And for the last 2 years, I've been the CEO of Envision Genomics, which is a whole genome sequencing startup analytics company focused on really changing the way we take care of people with rare, undiagnosed, and misdiagnosed diseases.
So what you're trying to say is that you're really bored and you have nothing to do.
Yeah. Well, I do a little bit of policy work in Washington as well with PTAC, which is a physician-focused technical advisory commission that looks at redesigning payment models for physician care. And so, yeah, I think life is an adventure and you just need to make it something totally fun, which is my purpose every day.
Yeah, absolutely. I think your story is so particularly interesting because of the different lens of healthcare innovation that I think that you've had the opportunity to put on, both being an early adopter of value-based care, also being an entrepreneur, being in nonprofit and for-profit. What advantages and disadvantages do you think you have coming to the innovation process as a physician, being an insider into the healthcare ecosystem?
So I guess an advantage I would have is that I practice regular old internal medicine in a clinic and have done so across multiple venues since I was first out of training in 1993. So I've been in everything from a 3-person medical practice that included me and my mother-in-law and father-in-law to a multi-specialty group to now a large health system that's an integrated health system. And within that context, I've seen the good, the bad, and the ugly in the way healthcare is and has been practiced, and have always been somebody who I think can say, well, there are things that we can do from this place in space that can just be so much better. And so it's really from that lens that I think I'm able to think through, what's out there in terms of technologies and other assets, people, and culture to sort of redesign the way we think about taking care of people.
So just kind of paint a picture for us from your point of view. What is it like riding the roller coaster of healthcare innovation?
Well, I'm one of those people that sort of tends to be on the bleeding edge. So, was one of the very first to be on electronic health record back in the early 2000s, one of the first to be what's patient-centered medical home. So a lot of times when you're an early adopter or in the innovation space, there's a lot of uncertainty. And when I look back now, I sort of smile because people occasionally want to teach me and lecture me about things that I was actually, in the early process of helping to design and build about 15 years ago when we didn't really know what we were doing.
Right.
Ended up, we make a lot of mistakes. You have to be willing to accept that and learn from them, and just continue to think about the fact that there's a lot of ability, I think, from most people that are educated people to criticize, but the creative process, which is so much more fun, is harder for people. We're just not used to doing it. And so what I have found in my career that's been most helpful is to take all those criticisms and just keep making things and building things. And that's really what I think innovation is all about.
How have you seen us be able to move the needle? I think you touched on something. There's a lot of criticism about, the old tradition, kind of the broken model. But at the same time, there's a lot of people out there that are doing really phenomenal things. Yes. So how have you seen the needle move?
So I will go back, way back, to when I was a kid growing up in rural North Carolina and watching my granddad essentially have a terrible last couple of years of his life because of terrible coronary artery disease, where he could hardly get from the house to the barn without stopping to take a nitroglycerin, and bypass graft was something that had just happened for heart surgery. But he didn't get it in time. He died. He went to visit one of the first heart cases in the county, which was a friend of his who did get that shortly before he died, and said something along the lines of, they just cut him open like a chicken breast, but now he's all better, or something like that. So anyway, we went from that to by the time I was in medical school at Duke in the 1980s, bypass operations were being done at big health centers and were this big fancy deal, but people were getting better. And then by the time I, was in training as an internal medicine resident at Wake Forest, it was stents that were out there. And, after that we got statins, and bypass went to community hospitals, and stents were, going all over the place and fixing things. And, my dad had a bypass operation in the 1990s at a community hospital, was home in 2 days. And then I've got a cousin who recently had coronary disease, and he was home in a day. Okay, so if you take the long view, either like in coronary artery disease, or you look at what happened within the HIV space, where when I was in med school in 1985, everybody was dropping dead to what's become a chronic disease. You do see remarkable progress on the science side or the medical side. But what we haven't realized is that we're now doing the same thing on the care delivery side. And so there's a lot of remarkable things out there. If you were in the middle of having a bypass operation in 1980 something, when it was still sort of early on, you wouldn't have imagined what it would be like 20 years later.
Sure.
There were drugs that would reduce the incidence of coronary disease and much better care. But it was a process that was going on. That's what's happening right now with care delivery. And it's because we're starting to think about things outside of just the technologies that used to be in the big hospital buildings, but what can be done in the digital world, what can be done with artificial intelligence, what can be done with genomics, with integration of information across multiple sources. And when you take that and you model it within the context of care delivery and payment model redesign, benefits redesign, then we are making progress. And I think that what we'll see over the next 20 years will just be some significant improvement, more than you can actually see when you're in the middle of the battles on a day-to-day basis.
Yeah, absolutely. So I think it's really good for us just to pause periodically and kind of go down memory lane like that, and really kind of, I guess I would say, celebrate some of the innovation and progress that we've made, not ignoring the fact that there's still a lot of progress that needs to be made, but it can be discouraging. And so we need to encourage ourselves that, yes, we are doing it. We can do it. Can we do more? Yes. And we're all working towards that. So a lot of the conversations that I have with innovators like yourself is just, how difficult and complex it is to commercialize an innovation in healthcare. So from your perspective, why do you think that some healthcare innovations succeed and some fail?
So, commercialization is all about the application of capital into a system that will allow something to scale and meet people's needs. A lot of innovation, people have a one-off solution, an app, if you will, that they're trying to superimpose on top of a very complex healthcare delivery system that isn't able to sort of accommodate that within the payment delivery model. So I think the best way to think about any type of innovation is, how does it meet somebody's needs? How are you going to scale it? And who's going to pay for it? And so much of healthcare, the person who's paying for it isn't necessarily the one who it meets their needs.
Right.
And so a lot of people come up with solutions to fix a particular problem, but they're not looking at it within the complexity of the system. Those that are successful either have created a bypass around that, as you're now getting with the direct-to-consumer movement in ways, or they're working to come up with a way of integrating into a system that actually makes it easier rather than harder. And that's not always easy in the innovation space.
Yeah, I think that's a crossroad that innovators always face. Do I try to circumvent the current healthcare system that is going to be a really long, arduous road for me, and go direct to consumer? And kind of look at more creative cash models, subscription models, all of the different innovative business model options that we have today. But then there's a cost associated, a much larger cost with educating and promoting to the consumer market. And then if you go into the healthcare system, it's how do you navigate that, right? How do you navigate that to make sure that you don't just get bogged down with something that's really innovative, but because of that payment mechanism, that payment models that are still somewhat outdated, how do I not just kind of find myself really right back where we were years ago?
Yeah. If you're dealing with health systems and you're selling into a health system, they've got about an 18-month budget cycle. And so just the process of dealing with large healthcare systems for what you need to do is a difficulty for many startups that have just lower amounts of cash and really can't sustain that, particularly because most of the venture capitalists are looking at a pretty quick return on investment. So part of our capital market's really just not set up for that. If you're talking about the payer market, you're basically trying to get someone to pay for your thing you've innovated. They have a very different set of way of thinking about things that have to do with clinical utility and evidence that's a little bit behind the way most innovators think about solutions. And so, can
you describe that a little bit more?
Okay, sure. So within my space, whole genome sequencing, we know that if you do whole genome sequencing on patients with rare, undiagnosed, misdiagnosed diseases under certain criteria, children with developmental delay, with seizures that are undetermined cause, people that have certain things that you just can't figure out. If you get that, if you get whole genome sequencing, you can sometimes save hundreds of thousands of dollars down market with respect to the cost of care. But they tend to do their analysis at the level of it being, here's one more $5,000 test, if you will, as opposed to saying this $5,000 test is going to save $200,000. And getting them to actually see that clinical utility is just a slow process. So that's part of, that would be one example of that.
Yep. So what phase of the commercialization process are you in now? Do you have paying customers? Are you still in kind of the pre-launch? Help us understand that.
We're right at the level where we've got to process it with a product that is ready to go to market, which is CoI'Q, which is a data analytic tool that can make a diagnosis from the genetics information in about an hour for things that used to take days.
Mm-hmm.
And so it requires certain licensing, which we have. We were, this is just sort of the nature of startups. We were ready to launch last year, had capital lined up, and the capital source was being led by someone who died unexpectedly at age 63 of an unlikely event. So this is the type of thing that happens in the startup world. We've spent
Talk about the wild ride of entrepreneurship, right?
Yeah.
I mean, you just can't predict that.
You can't predict that, no. And he was a good friend and a wonderful mentor, and it's very hard for me to, have a pity party for myself when I realized that he lost his life, and his family, is very much suffered from that far more than I have. But but nonetheless, that was just one of those things, and that's just the world of startup. So had you talked to me, a year ago, I would have said by this point we had a expectation we'd be about $3 million in the positive with respect to revenue. So in the startup world, things happen. Those are black swans and things like that happen. So we are in the middle right now of redesigning things around a merger process with another company that has a complementary business model. And when that happens, I think you'll be seeing some interesting things in the next few months to year. So stay tuned.
All right, that's great. So I think you kind of touched on this. I was going to ask you, or I am asking you, what are some of the biggest challenges that you faced as an entrepreneur? Certainly, having something like you just described happen is a huge challenge. I like to have really candid conversations about what it's like to be a healthcare entrepreneur, because if we share those realities, I think it's just very encouraging. Like, hey, I'm not in this alone, right? Man, it's happening to you too. I don't take it so personal.
Yeah.
And then if we share strategies of how we overcome that, then together we can kind of move the needle a little bit. So just kind of speak to maybe some of the other challenges that you faced, and what have you put in, ways that you've overcome them.
I'll give examples not outside my current company, but you talked about the search for capital. So my multi-specialty medical group, Cornerstone, very early on saw that there was going to be a move to value, and came up with a strategy to do that. That we knew it would require capital and partners as well as willing payers, and we went down that path and had some results in terms of lowering the cost of care by 20% in a very vulnerable, high-cost population of patients. That's been published, by the way, in the Journal of Population Health. But the payers were slow, and the politics changed. What looked like was going to happen after Medicaid expansion legislation got sort of confounded by the Supreme Court decisions. It really changed the trajectory of the market. So we continued to have results, but we lagged with respect to our ability to move as fast as we thought the market was going to fast. So we ended up seeking out partners for what we were doing, and those partners included LabCorp and Wake Forest Baptist, which at the time was an independent academic medical center in our community. And ultimately, we spun off a company called Chess, and that additional capital and the ability of that those resources has allowed Chess to be successful. It's now managing, I believe, about 100,000 lives in value-based contracts. It's been successful in multiple Medicare Advantage and Next Gen ACOs. And when Wake Forest just announced that it was going to merge with Atrium in Charlotte, which is one of the largest health systems in the Southeast, in their press release, they mentioned CHESS as being one of the resources and assets that they were bringing to the table for what they were planning. So if you looked back in 2013, when we were making these very hard decisions about, are we going to do this alone? We don't have enough money. Who's going to be our partners? To where we are now, and the fact that it's like that bypass story. We couldn't have seen where we would be.
Right.
But it was a very, very hard road. And the value that the shareholders of Cornerstone will have in CHESS over the next 10 years should be, multifold relative to the blood, sweat, and tears and hard work that we put into it in the late 2010 to 2013. But it's taken longer than we thought, and it took partners.
So what's that conversation like with the board, with the shareholders, with the investors of we're going to get there, but not yet. We're going to get there, but not yet.
Sometimes it's a very hard conversation. People are impatient. People are scared. They don't see the future. And sometimes you're wrong about, where the market's going or how fast it's going to go. But we thought all along that it was going to be about some very basic truths, which was there was a lot of excess expense in healthcare that could be improved by redesigning models of care that were much more patient-centric, that took care of their needs, where there was integrated information, and physicians that were managing this with a team of people that could greatly benefit from integrated information on everything from pharmacy to care model redesign. And we were very convinced that was the case, and that the market was going to need that because of all the trends that we're all aware of in terms of healthcare costs. And so that was a truth that, we had some early proof points that ended up being good evidence of that. And so as the rest of the market came along with the way we were thinking about it, then we continued to have ongoing success. And there's payers now who will not do certain types of contracts in this way without our being involved in our market, because they know that we know what we're doing. So that 10 years of experience has made a difference.
Kudos, right? Yeah, it's kind of a win. Yeah. So as you kind of went to market, both in your previous experience and your current experience, are you, having any type of like targeting or segmentation strategy where you're really separating the innovators and the early adopters and identifying and finding those and presenting your offering to them versus presenting that to the mainstream market that's not ready yet, that needs a different...
Absolutely. So within the context of whole genome sequencing and rare disease. One day, you and I and our children or our grandchildren will all have very inexpensive whole genome sequencing at some point in our lives. We're to be in a secure, safe, stored environment, and it can be accessed by any type of physician or patient when it's needed to basically inform about medical risk, possible disease, possible side effects from drugs. But that's not where we are right now. So where we are right now is that this technology is out there, it's getting cheaper, and the people who need it the most are those who are not very well served by our current healthcare market, which are those with mostly children with rare disease that are being misdiagnosed and underdiagnosed. So they end up at children's hospitals. So the people that will benefit from this now are at children's hospitals. And so the dialogue is with those that understand this, the children's hospital market. They know they don't have the resources to do this. We're making it less expensive for them so that they can order this testing. And we're serving as a source of expertise so that they can actually get it to the people that need it the most. Ultimately, the whole system will have this as a technology. But right now, there's probably 5% of the population is just extremely poorly served by our current healthcare delivery system, which is focused on chronic diseases and those with rare diseases need a very different strategic approach.
Sure.
And so the places that they go are the places that we need to be marketing and targeting right now.
Mm-hmm. So as we think about the commercialization process and all of the decisions that are made when you're developing that early adoption strategy, targeting, communication, branding, messaging, business model development, what are some of the strategies that you've deployed that would be valuable to share with our audience?
So I think one strategy that you have to deploy that we've done is to not be everything to everybody, but
so
realize
important
that there, you've got limited resources, limited capabilities, and so going towards those that need it the most and making it as easy as possible for them to provide that service. Sometimes you have to choose not to have somebody be a customer because it's going to require too much resource and it's not really where you're wanting it. But the flip side of that, sometimes you have to pivot. So you may think that you've got a product that's going to serve one segment, and in that segment, and you're wrong. And when that happens, you have to move, and you have to do it in a way that makes sense. So one example of this would be when we were developing CHESS, my population health management company, in 2012, 13. This was before Supreme Court decision on Medicaid expansion. So we had developed the model for the dual eligibles because we saw them as being somebody that under the Affordable Care Act, as Medicaid expansion happened, would be high cost, and that you could put some real innovation around giving them better care in a way that would be better for them and of lower cost. Well, when expansion didn't happen, we just had to do something very different with that, and really went in another direction towards Medicare expansion and Medicare shared savings, next gen ACOs. Not because we didn't want to serve that market, but because there was no way to pay for it. Now, if you look at some of the policies coming out in Washington right now, particularly with some of the focus on the waivers, that market will open up soon, but it wasn't there in 2012 just because of some policy changes.
Yeah, absolutely. So I talked to some innovators who are either physicians that are first-time turned entrepreneur, or maybe an executive or a leader within a big healthcare organization that have left because they've identified a problem that they want to solve on their own. And one of the things that's really interesting is for the innovators that are doing it for the first time, there seems to be a lot more naivete. I'm going to do this on my own. I've got all the answers. I understand the problem. I understand the solution. I understand my commercialization strategy and so forth. And whereas, other folks like yourself who have I've done this, there's lessons that you seem to take with you of we tried this and it didn't work, or, all of the different things. So what advice do you have for those listeners, those health innovators who are, may have a healthcare background, may not, but they're doing this for the first time and they're really, really passionate about the problems that they're solving and the technology that they're innovating. What advice do you have for them?
Don't be arrogant. Let's stay passionate and listen to people about what their real concerns are, because sometimes you have you're solving a problem that they don't think that they have, and sometimes there is reasons why it doesn't work, and get other people involved. I mean, most solutions are not one person's work, although that's sort of the way we tend to think about things in our culture, our individualist culture, but it's usually a focus, a team base. So many physicians, many entrepreneurs may not have the types of business skills that are needed to basically manage a larger team, to basically understand everything from business development, marketing, and sales. Some of them don't even know those are three separate things.
Right. Just that fundamental, that those are three separate things.
Yeah. Founders are not always the best ones to lead businesses to the next place and space. And sometimes passion can get in the way of execution. So I am very fortunate that I've been in multiple different types of situations where I've been in a medical practice that I was CEO of for about 20 years, that we grew from 4 or 5 people around the table to an organization that had, 2,000 employees, and had lots of people helping me. But that's a very, very different place and space in terms of managing something of that size and complexity, and building it and growing it, than in the situation I'm in right now, where it's a startup. And Chess, the company that was in between, which essentially was a spinoff out of a big company. You would call it a SkunkWorks initially, that became a separate company, was sort of in between that. So I'm a doc, right? So I have a lot of skills because I've done these other things, but it's always within the context of realizing that I'm a generalist, and that it requires a team of people, just like it does in the OR, just like it does everywhere else, to basically build businesses into something that can be important and meaningful. So a lot of folks that are at Startup Land, they don't get that perspective, because they've been frustrated with the system that they find dysfunctional and doesn't work. So then they leave to solve a problem, and they want to sell it back to that dysfunctional system. So you got to have your head around being part of something and understand your place in the ecosystem, I think.
10,000 of those stories, if not 100,000 of those stories, right?
Right.
So you touched on something, involving different people in the process. So I love what you just described, because you're talking about business building, right?
Right.
And in that it takes a village, right? It all starts with the people. Even when you're building a product, we're evolving other stakeholders in that product development process. What are some of the strategies and tactics that you've deployed at possibly involving patients and providers in the development of the solution, or even the development of the go-to-market strategy?
So I won't give you an example right now in the place and space I am with genomics, but I'll go back to what we were doing when we were building out some of the things at Chess. And this is the type of thing that doesn't sound like an innovation. It doesn't sound like a guy in a hoodie or a black turtleneck or something on stage. But we, as we were thinking about redesigning models of care around patients, we developed a committee of patients that we were from all walks of life, that were part of our, that were just like one of the other committees at Cornerstone. So we had finance committee and operations and all this, and then we had a patient committee. And they told us what their actual experience was. And they were very, as opposed to, what we thought we were providing. And, and from that, we learned a lot, and we understood what some of the, difficulties were. One thing that I'm doing right now that I am finding just so much fun is I'm working, doing some independent work for the primary care telemedicine provider. And I'm learning so much from these patients that have zero access to primary care, or desperate to find solutions for problems that the technology can easily provide outside of the traditional healthcare system. Sometimes don't know the limits of that. But I am learning more about the healthcare market in many ways that I didn't know than I have in 20 years, sitting in my practice or doing some of the things that we do in our extensivist transitional care clinic when I go back to Cornerstone to see patients. Because these are the people that never came to my office. And they're using a technology now. I've seen about 2,500 patients through an iPad just like this since February. Sometimes they're in their car, sometimes they're at work, sometimes they're at home, sometimes they're in bed sick. They're uploading pictures of their poison ivy for me to tell them it's poison ivy. And it's evidence-based. I'm getting patient satisfaction data back. But these are patients that they're calling because they can't get a refill. Their doctor's offices are closed, or they can't afford to go and see their doctor, but they can afford a copay for this type of thing. So sometimes just getting outside of what you usually do and getting another perspective, I think can make a great deal of difference.
It's just fascinating for someone that's been so entrenched in so many different facets that really can be that honest of I'm still learning, right? Because we are, no matter how much we know, we're always learning something new.
There's just so much stuff. I'm just this is why I couldn't ever specialize. I was a quintessential generalist. It's like, I can't imagine just knowing one thing really, really well. I'm just going to know a lot of things not so well, but a lot of things.
Right. Yeah. So some of the challenges with like patient and provider co-creation, some of the conversations that I've had around this, especially for a startup, is that, I completely buy into involving them in the process. Mm-hmm. It's not something that I'm opposed to. I'm eager to do that. But when I reach out to those folks, they're excited about what I'm doing. They're just really not excited about contributing their time for free. And then the innovators, are where they're bootstrapped, right? And they're strapped for cash. And so as they're making decisions of what they're doing with the limited funds that they have, allocating funds to pay those patients or to pay those providers for that feedback so they can co-create with them becomes a real challenge. How have you address that? Were you just finding people that you had relationships with, or people that were saying, I'm willing to give you some of my time for free? What did that look like?
In the example I gave with the patients, a lot of times these were people that had written complaints. They were passionate about a bad experience that they had. Yeah. We invited them to solve that. So these may not be the atypical people, but he was like, I just had a really bad experience with your organization. And so we're like, great, will you become one of our members of our patient committee and help us get better? And so that ended up, because it was meeting a need that they had. It was an emotional need. They were unhappy people that wanted to be part of something.
So true.
Within the context of other types of audiences, everybody's got moms and dads and children and cousins twice removed, and you can reach out sometimes to friends and family, not just for capital, which is the way a lot of people think about it out there, but in terms of product feedback. So you have to be, sometimes your family's the only one who's going to tell you something negative and critical about you. So it can be that way for your friends and family. Let them invest in your company, not just financially, but invest in your company with feedback. So that's just something I think all innovators ought to realize, is that the friends and family round is not just about money. It's about the village it takes sometimes to build something.
Absolutely. Well, Dr. Terrell, I thank you so much for your time and this just incredible wisdom that you shared with our audience today. It's been such a delightful conversation. How can our audience, our listeners and viewers, get a hold of you if they want to talk more about what you're doing or have some questions with their own commercialization process?
Sure. So you can reach me by email at gterrell@envisiongenomics.com. You can find me on Twitter at GraceT22, and I'm on LinkedIn. So I would be happy to have conversations with people through any of those media if it would be helpful.
Awesome. Thank you so much for your time today. What's the difference between launching and commercializing a healthcare innovation? Many people will launch a new product. Few will commercialize it. To learn the difference between launch and commercialization, and to watch past episodes of the show, head to our video show page at drroxie.com. Thanks so much for watching and listening to the show. You can subscribe to the latest episodes on your favorite podcast app, like Apple Podcasts and Spotify, or subscribe to the video episodes on our YouTube channel. No matter the platform, just search CoI'Q with Dr. Roxie. Until next time, let's raise our CoI'Q.